Hello everyone and welcome to today's Connect and Learn webinar, Trauma-Focused Treatment, Advancing the Evidence Base for Integrated Care of Addiction and Post-Traumatic Stress Disorder. Thank you so much for everyone for joining us today. Before we start, I'd like to acknowledge the traditional custodians of the land where we are presenting from today, the Wurundjeri people of the Kulin Nations. I would like to pay respect to elders past, present and emerging, and extend this respect to those First Nations people who might be watching this webinar live or later via replay. My name is Rebecca and I'll be facilitating today's webinar. This webinar is a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. However, we most warmly welcome all viewers across Australia. This webinar series is funded by the Victorian Department of Health, but hosted by Turning Point. We like our webinars to be as interactive as they can be, so please use your chat box to type your questions. Please direct those questions to Turning Point. They'll be collated for our presenters at the end, so please be mindful that all the questions will be asked at the end of the presentation. We also encourage you please to stay until the end. We have an evaluation to complete that will be shared via the chat box in a link. So thank you very much if you could please do that. I'd like to introduce our presenters today, Dr. Shalini Arunogiri and Dr. Jennifer Nation. Shalini is a consultant addiction psychiatrist and clinician researcher. She is Deputy Clinical Director at Turning Point and Deputy Head of the Department of Psychiatry at Central Clinical School, Monash University. Shalini's clinical and research interests include methamphetamine use and mental health problems and women's health and addictive disorders. Dr. Jennifer Nation is a clinical psychologist working here at Turning Point in the Coop Program. She delivers concurrent treatment for PTSD and substance use disorders. Jennifer's doctoral research investigated the relationship between forgiveness and well-being, and she has an ongoing interest in the interactions between psychological health and well-being. So thanks to them both for coming today, and I'll hand over now. Thank you, everyone.
Thanks so much, Rebecca, for that introduction, and thank you for joining us today. Really pleased to be able to join you to discuss this really important topic, and I think a topic that's on the minds of lots of clinicians who work in drug and alcohol services, as well as lots of consumers that we work with. So let's get started. So if you're here today, you probably already know a lot of this in the sense that trauma is a huge issue for people who come in through the doors of any drug and alcohol service. We know that trauma as a whole is arguably the single biggest risk factor for mental health problems as a whole, and it's implicated as both a causative factor as well as a perpetuator of substance use disorders. In Australia, nearly 1 in 2 individuals in substance use treatment, that's across all drug and alcohol treatment settings, report some symptoms of post-traumatic stress disorder. So that's 1 in every 2 clients that we see. The prevalence of post-traumatic stress disorder in Australia is lower than what we see in clinical settings. So nearly 3 in 4 Australians will experience some form of trauma in their lives, and that can range from a whole range of different types of traumatic situations. For instance, I've put some pictures of some common things that people experience. Approximately 4.5% of those individuals may go on to develop PTSD. So that's a much lower rate in terms of how much trauma is experienced versus the rate of actual PTSD. It's twice as common in women than it is in men, and there are a whole range of different factors for that. But 1 in 3 adults exposed to trauma develop problematic substance use. So that's the pointy end, I guess, that many of us that work in clinical settings see, is that those individuals who may have had trauma exposures all the way from childhood throughout their lives, actually coming in the door for help for their substance use disorder with this whole range of different things that they've been struggling with. So in terms of trauma and PTSD, I think it might be helpful to spend a little bit of time thinking about how we define these things and the context in which we conceptualize this when we look at treatments and research in this area. So I've lifted this definition from the Substance Abuse Administration in the US. And this is quite common in terms of commonality across how people define trauma. What's important here is that trauma is defined as something that results from an event or a series of events, but is experienced by the individual as being physically or emotionally harmful or life-threatening. So that severity that the individual's actually experiencing that as a life-threatening event to them is a really important part of how we conceptualize trauma and treatments for trauma. And that itself has adverse and lasting effects on that individual's function, their mental health, their psychological and social well-being, and spiritual well-being. So in terms of thinking about what is PTSD then, and as I've already mentioned, not everyone who has a traumatic exposure goes on to develop PTSD. And if we look at what this construct is of post-traumatic stress disorder, that's that's evolved over time, and it's quite a discrete sort of range of symptoms. And so when we define that, we're actually thinking about 4 main types of difficulties that the person might have challenges with. For instance, they might frequently re-experience the traumatic event through unwanted memories, intrusive thoughts, what we commonly describe as flashbacks or nightmares. So these are all kind of conceptualized under that re-experiencing phenomena. Also, this feeling wound up, this problem with sort of hypervigilance and hyperarousal, finding it very hard to kind of relax, finding it that they're often irritable or angry with other people, and that can cause interpersonal problems as well, and feeling like they're constantly on edge or looking out for danger. People might also avoid reminders of the event, so avoidance itself can be really problematic for a lot of people, particularly people who then have developed, for instance, substance use disorders, where the substance use itself can be part of that avoidance. For instance, people might be avoiding reminders that might be places, activities, people, or even thoughts or feelings that bring back those memories. Also, negative thoughts and feelings, for instance, feeling afraid or angry, a whole range of different things can be really problematic in their own right, and also compound the challenges that the person might be living with, for instance, making them more disconnected or more isolated. So these 4 kind of core symptoms of PTSD are really important when we kind of think about what sort of treatments might be effective, as well as putting on the overlay of having a substance use disorder on top of that, thinking about how we can treat the 2 together. The core PTSD symptoms have really been defined through the ICD and the DSM, the main classification systems in psychiatry. And if we think about that, the diagnosis of PTSD, and this is a really important change, in the latest version of the DSM, the DSM-5, moved from being thought of as just an anxiety disorder, and I say that in jest because anxiety disorders in themselves are a whole range of different problems that can be really challenging. But it moved from this class of anxiety disorders over to a new class of trauma and stressor-related disorders. So this class of disorders refers to PTSD, but it also refers to a whole range of other things might be related to mental health symptoms that might relate to original trauma. And as I was mentioning before, this conceptualizes those 4 main concepts and domains. Now, I'll spend a little bit of time just touching on this concept of complex PTSD. Now, complex PTSD and the concept of thinking about trauma and related mental health symptoms is a fairly new concept. Started being thought about in sort of 2012, 2013 onwards, and now is within the classification systems that exist. What reflects on that is really because it's such a new concept, the research and much of the research on integrated treatments, for instance, or what works for people with substance use and PTSD may not necessarily have touched on the phenomenon of complex PTSD. So that's really important when we think about who we're actually seeing in front of us, whether a core PTSD construct is more kind of aligned with what they're experiencing, or whether a complex PTSD construct is more aligned, because the treatment approaches we might use for both of those might be different. For complex PTSD, this is a broad kind of conceptualization of the main challenges that people experience. And just to touch on the differences between PTSD and complex PTSD, there's a reference there that I've included that's a really interesting paper from 2014. And here basically there's a list of different symptoms that are conceptualized as core PTSD, complex PTSD, and borderline personality disorder. And so these are different constructs. And I guess over time we're learning more about how these map onto and interrelate with each other. But this was one of the earlier studies that took a group of about 280 women who had gone in for an assessment for a clinical trial of PTSD and had a whole range of different measures. And during that process, they used an approach called latent class analysis, and that approach basically clusters symptoms and tries to understand if these symptoms are actually distinct, these symptom clusters. And suffice to say that from that map, as you can see, they've actually looked at these different sort of symptom constructs as being quite different. So for instance, an individual presenting with sort of core PTSD presents with a different kind of presentation when you look at the whole range of symptoms, as opposed to complex PTSD and as opposed to borderline personality disorder. So there is clearly some grey area in between all of that, between PTSD and complex PTSD and BPD, where individuals may actually have a constellation of symptoms that overlap. But by and large, if you look at it in a group function, that there is actually evidence to suggest that these are differing kind of phenomena. Again, the reason why that's important and why we're touching on it today is that that's relevant when we think about what treatment approaches might work well in this area. And so thinking back to an individual level, why would someone with PTSD be more likely to develop a substance use problem? So what's really important is to kind of think about all of the different things that interplay with experiences of trauma and then reactions to trauma and how that might actually interrelate to why this occurs. So we know that people with a trauma exposure may then develop a range of symptoms that make them more susceptible to developing a substance use disorder. So someone might actually develop susceptibility to both a PTSD and a substance use disorder. But also what we often see in a clinical setting is that there may be common factors that underpin both, but also self-medication, where someone might be using substances to manage the symptoms of their trauma. So what's important is, I guess, when we look at comorbidity as a whole, we can spend a little bit of time trying to understand which came first and what led to the other. But when we're treating PTSD and substance use together, the most fruitful approach is really to kind of understand that the whole person kind of sitting in front of us, it really has both disorders present, and that each disorder maintains and exacerbates the other. So once you've got kind of someone who's struggling with both, it's about thinking about how we treat both in and of themselves. So in terms of addiction treatment, the presence of both those disorders at the same time is associated with a higher rate of severity of the disorders, lower level of function and quality of life, and poorer outcomes overall. That might include quality of life outcomes, but also outcomes for PTSD and substance use specifically. So this research has been shown over and over again over decades, and so that's why thinking about how we can help someone manage both disorders is so relevant. For instance, if we only treat one of those disorders, PTSD or substance use by itself, we know that the other doesn't remit and that it actually can get worse in the long run. So PTSD itself can be debilitating, but its clinical course is worsened by having that co-occurring substance use disorder. And so for people who present with both, we also see more inpatient hospitalizations, for instance, and more difficulties with treatment responses. We also see that compounding of sort of interpersonal and legal problems that can lead to more and more disconnection, as I mentioned before. So for the addiction treatment settings as well, what we know is that, for instance, offering someone a detox or withdrawal admission doesn't necessarily treat the PTSD that co-occurs with it, and that people are often in this cycle where they may have a period of absence or recovery, but then actually use substances again in order to suppress symptoms if those symptoms are still there and untreated. Again, emphasizing why it's so important to treat both. And so, changing tack a little bit, we might move a little bit to talking about trauma as a whole and trauma-informed care principles, and then after that unpack what it means to look at trauma treatments. So trauma-informed care as a definition, you might see it quite a lot in sort of treatment planning documents as well as in the mainstream media nowadays. And trauma-informed care is more than one thing. It's an approach that actually looks at how we work with individuals, but also looks at how a service as a whole and a system as a whole engages with an individual and a community. So it extends much further than just the clinical principles of how to operate in a clinical setting. So the differences here are really that trauma-informed care is about talking safely about trauma. So on a one-on-one with the client, it's about being able to identify that if trauma exists, where the bounds are of that discussion. For instance, operating in a very sensitive fashion, not pursuing information if the client doesn't feel ready to talk about it or doesn't want to talk about it. Not basically opening up that box and then not having necessarily the individual be able to kind of put that stuff back in the box. So there's lots of information and training and resources out there on how to do this effectively. But broader than that, broader than the clinical discussion, is also principles that guide clinical and organizational practice at a system level. An overarching framework for a sector as a whole on how to actually operate in a trauma-informed fashion. And this includes things like not asking information for assessments over and over again, not actually requiring people to walk in through multiple doors and speak to multiple individuals. So these are all parcel of that. So in terms of trauma-informed care, where we are in Australia right now is really this overarching principle that mainstream treatment needs to be offered in a trauma-informed manner. And there are a whole range of resources to support that. I've just touched on a few of these resources. There's tons of documents out there for you to go off and look at, but these are particularly relevant to our sector. It's a fantastic document by Regen that I highlight there, and also a couple of training booklets and training resources that are available. Both Phoenix and Blue Knot run training for organisations as well. So something to look out for. And there are also a whole range of resources for clients and families. And I think that's really, really helpful space to spend some time with your client talking through what these definitions mean, what, for instance, complex PTSD or PTSD might refer to, and directing families similarly to these resources. So thinking about trauma-informed care, now we're moving on to thinking about treatment. And so treatment is a little bit different from thinking about trauma-informed care, where that's more around kind of assessing what's going on for an individual, but not necessarily offering treatment for that. Now, when we think about treatments as a whole for traumatic disorders include trauma-focused treatments and non-trauma-focused treatments. So trauma-focused treatments, which is what we're going to spend a bit of time talking about today, is really kind of targeted at the memory of the traumatic event and its meaning. Not all treatments need to do this, and so for trauma-focused treatments, that is the core of what they do. And examples, for instance, include exposure-based therapies, which we'll discuss in a bit more detail, and also EMDR or eye movement desensitization and reprocessing. And those are really evidence-based treatments that are supported by decades of research to be really effective in this area. Now, non-trauma focused treatments, in contrast, they focus on the present or past aspects of life other than the trauma. So they could include sort of practical skills. They might include a whole range of different things like stress management, mindfulness, supportive or non-directive therapy, relaxation. And these, importantly, do not require clients to revisit or reprocess that traumatic memory. So that's quite different approach. And I think, it's worth spending a bit of time kind of thinking about that contrast and thinking about who's kind of most appropriate for referral for some of these types of treatments versus others. So far, these sort of treatments have very limited evidence base in conjunction with substance use disorders. So for instance, looking at concurrent treatment of this together with the substance use disorder, the majority of evidence really is focused on trauma-focused treatments and how that works. So integrated therapies, as I was mentioning, really look at treating both disorders at the same time. The definition of integration can differ based on different treatments. So for instance, you could see the same clinician and get both substance use disorder and PTSD treated together. And certainly a lot of the literature is focused on that. This can also happen in practice in service settings, for instance, where two clinicians on the same team who are very much working in tandem, or for instance, two services that might be very much working in tandem. The level of integration is important, the level of kind of liaison between services, liaison between clinicians. Essentially, the individual needs to be getting a treatment as a whole, that they conceptualize as a whole. And so for integrated treatments, it's challenging to treat both those disorders separately. And what we know is when we treat them together, it is still fairly challenging. Dropout from treatment can be high, and there's challenge in terms of different types of treatment approaches and matching that to where the person's at. So I'm just going to highlight a couple of reviews in this space that are really helpful. One was done in 2012, and just highlighting it because it gives you a bit of a sense of the types of treatments that are available in this space. They include cognitive behavioral therapy-based approaches, as well as a range of other approaches that include exposure. And then the more recent review, just there for you to note really, but I can direct you back to the reference if you're interested to learn more about it. This was a systematic review that looked at 14 randomized controlled trials in this area, and included a majority of those trials that looked at trauma-focused CBT type interventions, so cognitive behavioral therapy interventions, delivered alongside the substance use component. So that's a really important part of these integrated treatments, that individuals don't need to be abstinent before they come to these treatments, that individuals are coming in with active substance use, and that we're actually stabilizing the active substance use as well as treating the trauma at the same time in a safe and effective fashion. And so what this review found was that the integrated trauma-focused treatments were more effective than treatment as usual in these settings. Treatment as usual could mean many things, generally sort of supportive counselling or relapse prevention, for instance. And also that these types of interventions worked really well for PTSD symptoms, both at the end of treatment, but also down the track, so 5 to 7 months later at follow-up. For substance use, what the review found, taking all this evidence together, is that substance use at the end of treatment didn't necessarily differ from treatment as usual, but at follow-up time point, for instance at 5 to 7 months, that the substance use outcomes were better in people who got that integrated treatment approach than people who got treatment as usual. So that's really important to kind of think about, because that highlights what many clients tell us, for instance, that, for instance, if the substance use gets better after an episode of counselling, but if they have an underlying PTSD, that actually results in relapse down the track. And that's where we're seeing those differences kind of follow up. So what's also important in this review is that they also found that the treatment is challenging. Many of these integrated treatments can be quite challenging for people to remain in. And so fewer participants in these interventions as a whole completed the trauma-focused interventions than the treatment as usual. So they had higher dropout rates, something we'll talk about a bit more. So in terms of the Coop program, which is one of these trauma-focused treatments, I'm going to spend a bit of time telling you a bit about our own journey through delivering Coop here at Turning Point, and some takeaway messages, I guess, from the drug and alcohol treatment sector thinking about this. So the Coop program is an integrated intervention that evolved from an intervention that was focused on cocaine use disorder in the US. And it's an integrated evidence-based treatment program for both PTSD and substance use disorder. And it synthesizes 2 types of treatment. So CBT with prolonged exposure taken together with substance use. So the primary treatment goals are both to reduce the symptoms of PTSD using the prolonged exposure, as well as to reduce the substance use using CBT techniques. And so it's been studied extensively, both in the US as well as internationally. We've included a range of the current as well as older studies that have been done in this area. And the research to date includes 507 participants, which includes 4 randomized controlled trials, 2 open label, 2 case reports, and 2 current studies. The Coop that's running out of Matilda Center, so Coop for Adolescents, Coop A, as well as a current trial that's running in the US with Coop, as well as a medication, oxytocin. So both of those trials are currently ongoing. The findings across these trials generally have shown that Coop is safe, that it's feasible, that it's effective, so it reduces both PTSD symptoms as well as substance use symptoms. And so it's really important to kind of, advance that evidence base in terms of thinking about how we implement it here across Australia. So I might hand over now to my colleague Jennifer, who's going to tell you a little bit more about the Coop program.
Thanks, Shalini. Hello, everyone. So my focus today is to talk a bit more about the practical implementation of the Coop program. The illustration there shows you the publication, which is the manual that we use. I want to talk about how we're currently delivering Coop, which is, as Shalini said, a specific concurrent treatment for PTSD and substance use disorder. So at Turning Point, we're offering Coop as written up in the manual. It's a structured treatment program. We're offering it to women only at this stage, women with PTSD and substance use disorder. It involves an initial psychiatric assessment or joint assessment and up to 12 treatment sessions. And those treatment sessions are expected to cover a period of about 4 months. So we're offering them weekly. They're 90 minutes long. I'll say a bit more about why that is later. We invite referrals, and in fact referrals are required for the program, and we prefer those to come from people who have some involvement and some knowledge of the clients, so GPs, case managers. We're offering it statewide in Victoria, although I have to say at this stage we have clients mostly from the metropolitan area. I think one comes from the country at the moment. And there's a range of eligibility criteria for the program. So the eligibility criteria are focused on the likely effectiveness, or we want to maximise the likely effectiveness for the program, especially since it's pretty demanding in terms of attendance and between session work. So we're offering it for women aged 25 and over who have current substance use problems, who have PTSD symptoms. We don't necessarily need clients to have to meet all the criteria for PTSD, but it is important that they've experienced a traumatic event that fits the criteria for being very threatening, life-threatening. It's also important for the potential client to have symptoms in at least 2 or 3 of the 4 areas that Shalini was describing earlier. Clients need to be willing to change their substance use in the direction of less harm. They need to be willing to complete between session exercises because they're a really important part of they've been demonstrated in the research so far to be an important component of the effectiveness of the program. And they need to be willing to travel and able to travel safely to appointments in Richmond. There's also a range of exclusion criteria or potential exclusion criteria. So COPE, and these are focused around making sure that the treatment can be offered safely to clients. So it's not suitable for clients with current or high risk of suicidal behaviour, serious self-harm within the last 3 months, current family violence, current psychosis or severe dissociative symptoms, people who are highly substance dependent. So it's a bit of a sweet spot working out whether a client is ready to proceed to this treatment. They obviously will still meet criteria for substance use disorder, but a client who's highly substance dependent can have difficulty engaging in the program. There can be increased risks associated with travelling to and from sessions and engaging in the between session tasks. For example, if clients are unable to manage not to be highly sedated during the treatment, that interferes with some of the processes. And also using substances to the degree where they're unable to learn and recall what's happened in the sessions. The other final exclusion criteria is someone who has a very poor recall of the traumatic event. So this is an exposure-based treatment, so it's really important that we are able to select an index trauma, the most distressing trauma that the client's experienced. Often, because this is a comorbid client group, often clients have been highly intoxicated at the time of their trauma. They may have received a head injury during the course of the trauma event. But we do find that some clients who've had those experiences still are able to recall sufficient for the treatment to be effective. So that's something that we figure out during the screening and assessment process. Sorry, just checking my notes to make sure I said all the important things. We go through a pretty extensive intake process, and this is important to make sure we screen out people who aren't appropriate for the program, and we get a bit of a sense right from the beginning of the client's readiness to engage in a trauma-focused treatment. So on receipt of the referral, we usually have a chat with the referrer if we need to clarify anything on the referral, and we have a conversation with the client to make sure they understand what they're letting themselves in for, and explain, give them an outline of the program and get a bit of an idea of their availability and their preferences for treatment. We send them some screening questionnaires, and once we've received them back from the client, we have a chat about them at an intake team meeting, which is attended by the 4 psychologists that work in the program and also the addiction psychiatrists who are involved in the assessment. If we think they're ready to proceed to the next stage, we offer them a biopsychosocial assessment, which usually takes a couple of sessions. It includes a joint assessment with the allocated psychologist and one of the addiction psychiatrists, and we do a diagnostic interview for PTSD to get a good sort of baseline sense of what their symptoms are looking like. And if the program is not suitable for the client, we have a chat with them and or the referrer about some alternative options. At this stage, we're about 8 months into the program. We've declined about 23% of referrals, usually because there's important information or important eligibility criteria missing, like the client doesn't have an active substance use problem, they're still at risk of family violence, other safety issues. We do also have about 20% of referrals we're unable to get in touch with the clients right from the get-go, or they don't return their screeners. And then we've got about 14% of clients, once they've heard a bit more about the program, decide not to proceed at that time. So all in all, we accept about 43% so far of referrals into assessment and or treatment. The assessment, this won't be news to a lot of you, I'm sure, because I imagine most of you are from the AOD sector, but the assessment involves a pretty detailed look at the substance use disorder. We want to know about the amount, frequency, pattern and severity of dependence for each drug, the function and the context of the use. We find out about the traumas that they've experienced and their current trauma symptoms and the severity of those. We look at the risk of self-harm or harm to or by others, and we get an idea of the other services involved and their other formal and informal supports. Very few, because we screen so thoroughly in this program, we don't decline many clients at this stage. When we have, it's usually because they haven't met the PTSD symptom criteria, and sometimes it's due to a very high risk of relapse to unsafe levels of substance use. So next I want to give you an overview of the treatment. There are several components. It's a combination of two treatments. Prolonged exposure, which is based on the work of Edna Foa and others, and CBT techniques for substance use based on the work of Kathleen Carroll. So the treatment starts though with quite an emphasis on psychoeducation. So we introduce clients to the idea of monitoring their symptoms and understanding how their current life experiences, their daily distress and reactions and behaviours are related to their trauma. We look at the interrelationship between PTSD symptoms and substance use and get a more nuanced understanding of how they interrelate for each individual. And we can provide handouts for family or carers or other people involved. The prolonged exposure treatment, not sure how familiar some of you will be. Exposure is a sort of well-established approach to treating a range of anxiety or fear-based disorders. And I guess if you have a think about a natural reaction, if we know we're a bit scared of something, like people around here know that I'm not too comfortable driving on the freeway, the more I do that, the more comfortable I feel. So it's an approach-based treatment. It involves two main techniques. It involves imaginal exposure, which targets avoidance of the memories, the thoughts, the feelings about the traumatic event. And we do that by repeated retelling of the trauma during the session and processing the thoughts and feelings that come up during that retelling. So we kind of, over a number of sessions, empty the well of everything that's and support the client to develop a more constructive narrative about the trauma, something that they can live with a lot more comfort. In vivo exposure is the between session work. So this exercise targets the situations or people or places or objects that the client might be avoiding because they present reminders of the trauma. So that can range from driving across a bridge where you've had a car accident, or going to a supermarket where you had a panic attack one day. So the range of watching certain TV shows, meeting certain sorts of people. So a range of things that people have been avoiding in day-to-day life. And we, collaboratively devise experiments where the client can engage in contacting or experiencing those situations and evoking the fear response, and then learning how it habituates and how and developing their coping strategies. That's all I'll say about that. It's quite a complex topic, but happy to answer some questions about it later. The CBT techniques will be familiar for any clinician working in the AOD setting. This is based on the work of Kathleen Carroll, but it involves identifying and managing triggers and cravings, thoughts about using, reduction in use, refusal skills, relapse prevention skills. And the breathing retraining is the only sort of active fear or anxiety management technique that we teach in the program. So the breathing retraining is a technique to manage anxiety and fear and cravings. A typical session, as I said, the sessions last for 90 minutes. At the beginning of the session, we monitor progress. So the clients do a fair bit of work between sessions, but we're also monitoring their symptoms week to week. So they complete a questionnaire about their PTSD symptoms, and they complete a diary about their main substance of concern. We review between session tasks, and then we spend part of the session focusing on trauma and PTSD, and then shift the focus to the substance use disorder. And then we plan new between session work. So homework is a really important component of this treatment. And I calculated once that if a client, the theoretical client that does absolutely everything you suggest and all the homework, would be spending 6 to 7 hours on homework between sessions. So homework involves listening to recordings of the session, and then in particular, once the imaginal exposures have started, listening to recordings of the imaginal component every day, and monitoring their levels of distress as they do so. We usually have a bit of reading to do, especially in the early parts of the treatment. There may be specific AOD related homework that you might be familiar with, like completing cravings diaries or relapse prevention plans. The in vivo experiments, which can take up to 45 minutes each time, usually done a few times a week, and regular practice of the breathing retraining. So finally, before we get to questions, I wanted to say a little bit about the challenges and what we've learned from delivering this program for the first 8 months. So the intake and screening process was an important one for us. We wanted to be really careful that we offered the program to people that were likely to benefit, like that there would be a reasonable return on their effort in the program, and also would be able to engage safely. So the intake and screening process helps us determine treatment readiness and suitability, but it is time consuming and it can delay commencement of the program. So we're not great at sort of saying, yes, you're coming out of detox next week, we'll start off and we'll have your PTSD sorted in the next 3 months. That's probably not going to work that way. So that's been more work than we expected, but we do think the screening process is a nice introduction to clients to the idea of talking about and thinking about PTSD symptoms and monitoring their substance use. So in a way, it's a little bit of exposure right from the start, even sort of talking to us during intake about how the process works. So we think that explains the high sort of, or the low acceptance rate into the program, because we're doing that screening. But yeah, it does mean that we're doing a lot of work and not necessarily bringing a lot of clients into treatment. However, we think that some of that screening process is also useful because it does serve a psychoeducational function. For clients, the time and the women that we're working with, a lot of them have concerns about childcare, some of them work. So it can be quite hard to fit a session in the day because they're long. It's only half an hour longer than a regular session, but clients are also often travelling from outer suburbs, and so we find that a lot of people prefer to come in that sweet spot between about 10:30 and 2. We can't fit them all in. So that's been a learning, and it's impacted us more than it did in our previous program. The other challenge has been face-to-face versus telehealth delivery. And that relates to, we offer the program face-to-face and we prefer them to come in. But as we all know, sometimes we need to deliver the program by telehealth because of access issues or lockdowns. So far we've found that clients are pretty reluctant to engage in some components of the therapy via telehealth. So we're still working on that. We know from our collaborators in the US that the program is safe to deliver via telehealth, but we're still working on that. I could go through reasons for attrition, but I'm getting some looks. I think it's time for us to proceed to questions.
Thank you very much. Do you mind if I start with the COPE related questions first?
Sure,
and
that
then
might
maybe
be
leave
me.
some for Shalini?
And if they're too hard, I'll give them to Shalini.
Yes. Are you accepting new referrals at the moment, and how do people access the service?
Thank you, good question. So on our website, the referral form is available, and a little bit of information, like the information I gave you about inclusion and exclusion criteria are on the referral form. You can email them to our intake email address, which is on the form on the website. I think we're providing a link in the slides. Yep. Yes, we're accepting new referrals now, and
Thank you so much.
yes, go for it.
Why was COPE only offered to women?
Good question. I'll have a go if Shalini wants to add anything in. We offered it to women because women develop PTSD as a result of trauma at the rate of 2 to 1 compared to men. So that was the main reason.
Join you up here. I guess just building on that, the other main reasons were a lack of sort of women-specific treatments in drug and alcohol more broadly. So we know that women are kind of like overrepresented when we look at PTSD and substance use together, but also that when we look at what needs to be offered in a sort of a safe and effective setting, there were specific factors to think about for women as opposed to men. And so that was the main kind of underlying purpose. There's also a little bit of evidence from overseas in testing this out in settings where they've been offered to women, and so that we knew that was also a safe and effective way to kind of proceed.
Does COPE cater for women with disabilities?
Yeah, that's a really good question. I guess it depends on the definition of disability here too, because I think we're talking about women who might come from a range of backgrounds, including significant mental health problems too, which are also considered in that whole same spectrum. I think when we're thinking about physical disabilities specifically, or intellectual disabilities, that's another kind of thing to think about. I think what we do, and as Jennifer mentioned, sort of that extensive assessment process, is trying to understand where women are coming from and what that might be physically also where they're coming from and what needs to be kind of adapted to allow that. I think the one challenge, I guess, this being a very cognitively heavy sort of treatment program, is that we'd really need to kind of work with the client to understand if there's a level of intellectual disability, whether this is the right treatment approach, because it does rely very heavily on someone being able to work with kind of executive functions, being able to plan, organise, and also reprocess that traumatic memory. So that might not be the best fit. But in terms of other types of disabilities, I think it's about kind of reaching out to the team and working with them to try and understand if things can be adapted. Absolutely.
Thank you. What if women have not had a formal diagnosis? Do the clients need to be diagnosed with PTSD prior to applying for treatment?
Yeah, no, absolutely not. So I think one of the challenges that we find in working with comorbidities in general is that there's not a lot of services that can give a formal diagnosis, or finding that can be quite challenging in itself. I think Jennifer's kind of taken us through some of the main factors that we know that the treatment works better for. So for instance, understanding some of those core PTSD symptoms. For instance, is someone experiencing lots of nightmares or flashbacks or re-experiencing phenomena, that might mean that the treatment's more effective. So I think that's enough for us to be able to look at that referral, and so we get that referral and actually work quite closely with the referrer and the client to understand that. And then the next step in that, with that assessment process, is seeing one of our psychiatry team and our psychology team to develop that and do a diagnostic assessment. So that will be part and parcel of the assessment anyway.
Thank you. Is the Coop program a combo of group and one-to-one? If group, what is the approximate group size, and are they closed groups?
Yeah, it's a really good question. The way we're delivering it certainly is all one-to-one, so there's no group element to the Coop that we're delivering here at Turning Point. There have been other iterations overseas, and what I'd really suggest too, if people are interested in the intervention, is we've given you sort of a flying overlay of what it is. But the manual that was on one of the slides, the picture of the manual, if you actually Google that, you'll be able to find the manual online and either purchase it or read more about the treatment, and that kind of takes you through some of that. But certainly in terms of the format, all of what we offer is individual.
Thank you. Do you match the clinicians to the person? Given you are working with women only, are all your clinicians female?
I'll just touch on that, and I might hand over to Jennifer as well. We're certainly very cognizant of that, and so that's something that we've kind of taken on board, and I think the majority of our team is female, but we do have male clinicians as well, and we work carefully with the individual, the client, both in that pre-screening process as well as in that assessment process to understand if that's going to be a reasonable fit or not. Might hand it to Jennifer to speak a bit more about that.
Thanks, Shalini. I'm not sure I can add a lot, but we ask clients if they have a gender preference of their therapist. So that wasn't something we did initially, but after we had we got some feedback and we decided to be overt and ask about that. So clients express a preference for mostly a preference for a woman, especially if they've had sexual trauma, but also some have expressed a preference for a fella, and quite a few don't mind. So we think it's better just to ask up front.
Yes, Thank you, Jennifer. Given that many PTSD SUD clients have childhood sexual abuse as the primary traumatic event, how is exposure therapy adapted to be suitable for them?
Yeah, really good question. Based on the research that's been done so far, we believe it's effective for people with multiple traumas and with very early traumas. Where it can get tricky, I guess, is if the client was so young when the trauma occurred that they don't have a good verbal memory of what happened. It's kind of, I guess that question is a bit related to another question that we grapple with quite a lot, and all of the clients that have been referred to us have had multiple traumas. So we don't have anyone in the program or who's been referred to us who's experienced a single traumatic event. They've all had multiple traumas, and most of them have had traumas of different types. So we work with the client to identify the index trauma that's causing them most distress in the present day. It's in terms of their intrusion, their re-experiencing, their hypervigilance and their avoidance. So yes, we are working with clients who had childhood sexual abuse, but it's can be a bit dependent on the particular event and the specific client.
Thank you. That actually answers another question that we had, so thank you very much. Many clinicians in AOD and other services like to work in a trauma-informed way and would like to support clients in moving towards level 1, the stabilisation stage of trauma processing. Is this advised, and are there any resources you have to support us in this?
Yeah, I think the resources that Shalini cited earlier would be really useful. The Blue Knot ones in particular, they have a really good manual about that. This program is sort of positioned sort of in terms of those that stage of stabilisation. It straddles stabilisation in the next phase, which is more processing oriented and more trauma focused. But we find that so in our treatment, the early part of the program focuses on stabilisation, and sometimes we have to lengthen that a little bit. So I'm not sure if I've answered that question adequately.
I'm not sure. Maybe if the person that asked if they want to make any more comments, but we've got quite a few to get through.
We'll move on.
Thank you. Are there any affordable EMDR practitioners in the Outer East? Can it be bulk billed?
I don't know. We don't offer EMDR. I know a lot of psychologists in private practice do have trained in EMDR and offer it. If you're wanting it bulk billed, I would suggest you look at the PHN funded programs. So in the East, I think it's called... No, that's Northwest. If you Google Eastern PHN, Primary Health Network, mental health, there'll be a stepped care model, and they offer no gap psychology services. So it'd be a matter of seeing if they could identify someone who does EMDR.
Thank you. One of our viewers has said that CoHealth have been offering. Yes. Are there any culturally appropriate resources available for First Nations people to give to clients?
I can take that. Yeah. Do you want me to? Yeah. So I guess just building on that question, I guess the assumption is resources on trauma or trauma exposure or trauma treatments, I suppose. I think there are a whole range of resources in the AOD Knowledge Centre, which people might be familiar with, and also direct people to the Phoenix Institute who have other resources. I'm not specifically aware of anything being done with First Nations populations around concurrent treatment. And certainly the types of trauma, colonisation specifically, is not an aspect that's touched on in existing sort of trauma-focused treatment approaches necessarily. So I would think that an adapted treatment approach would be really necessary, but I'm not aware of one that exists in terms of concurrent substance use and trauma treatment. If anybody who's listening is aware of one, please feel free to chime in the chat. I'm keen to hear about it.
Thank you. We might just do one final question, because Shalini, I know that you've got other slides to show with resources. Are there challenges with other systems such as family court and child protection recognising this work?
Yeah, it's a really good question. I think in terms of where this program sits as a pilot program, we're really aware that individuals might be coming from a whole range of different kind of contexts. For instance, women who are currently experiencing family violence, women in that sort of early stage of child protection service involvement as well. And I think that can be really challenging for people to kind of have that context and overlay when they're trying to kind of move forward with sort of trauma recovery as well. I think part of this process as well in delivering it in sort of more mainstream treatment outside of clinical trial is getting that awareness out that approaches like this can be really effective. They take a lot of time, they take funding and energy, but they can be really effective to move people from where they're at. So I think we're at very, very early stages of being able to do that.
Thank you very much.
I might just move on just with some resources and references, and then we might share the evaluation links with you guys. So if people are interested, there are other sort of treatment approaches that are available as well. Coop, as I mentioned, is currently in a trial for adolescents operating out of New South Wales, and so that's available online. And also Become, which is a current trial currently happening through the Cracks in the Ice team with Professor Francis K. Lampkin. And that's an online self-guided narrative therapy-led intervention. And so that can be an option for lots of people who might be currently not looking at sort of trauma-specific focused treatment approaches that we've discussed, but might want to go off and have a look at this. So really encourage people to have a look at the site. We've taken the question, so I'll move on. And in terms of some of the references we've discussed, those references are there, but also our email addresses. The second email address is where to email through if you've got any questions about Coop or have referrals that you want to send through. So feel free to do that and reach out to us. Thank you so much for joining us, and we might leave it there. Thanks so much.